And I would like to present a rare complication of a disease which we see pretty often, which is acute pancreatitis. So this particular case report is about a 27-year-old male patient who presented to the OPD with the following complaints: pain abdomen in the last 7 days, recurrent vomiting, constipation and abdominal distensions in the last 3 days prior to presentation. He was apparently asymptomatic 7 days back when he had developed pain abdomen, central dull aching radiating to the back, aggravated on intake of food, partially relieved with NSAIDs. Recurrent vomiting with gastric contents, non-projectile, aggravated on food intake and relieved with antiemetics. He was also complaining of constipations in the last 3 days, passing flatus, and he was also complaining of abdominal distension for the same duration. There was no history of similar episode in the past. No other significant past history. The patient is non-vegetarian by diet. There was history of alcohol intake, mostly on weekends in the last 3 to 4 years, approximately 10 to 12 units of alcohol in one sitting. The last alcohol intake was 2 days prior to onset of symptoms.
How much is for 1 unit?
Sorry, sir?
How much is 1 unit?
1 unit is about 25 ml of a hard liquor. So 250 ml. 250 ml. So the last intake was 2 days prior to onset of symptoms. On examination, there was the BP was 100/66. He was having tachycardia, tachypnea, and he was afebrile. His sugar was 103 milligrams per deciliter. He was clinically dehydrated with dry cracked lips and sunken eyes. CVS chest and CNS examination were within normal limits. The abdomen was distended. All quadrants were moving with respiration. There was umbilical region tenderness with no shifting dullness of fluid thrill, and there was sluggish bowel sounds. The hernial sites were normal. So clinical impression of acute pancreatitis or alcoholic gastritis or gastric ulcer was made, and the patient was started on conservative treatment. He was kept NPO. He was given aggressive IV fluids, PPI and antiemetics were given, NSAIDs for abdominal pain, and RT insertion was done. Routine investigations along with pancreatic enzymes were sent. Chest and abdominal X-rays, ECG, ultrasound, ABG, urine routine were done. His blood counts came to be 14,300 with 70% neutrophilic predominance. There was AKI with urea of 43, creatinine of 1.6, sodium of 149. Liver enzymes were slightly raised. Serum amylase was 1,288, lipase was 2,870. The X-rays were normal. The USG was suggestive of enlarged hypoechoic pancreas with mild peripancreatic fluid. His CRP was 48 milligrams per deciliter. Procalcitonin was 0.3 micrograms per liter. The final diagnosis of acute pancreatitis was made, and conservative treatment was continued. The abdominal pain, vomiting and pancreatic enzymes gradually reduced over the next few days. However, the abdominal distension worsened and constipation persisted. TLC increased over the next 3 days, and the patient was started on IV piperacillin, tazobactam and metronidazole. Gastro opinion was taken and the advice was incorporated. By day 4, the TLC increased to 20,180 with 83% neutrophils, and the enzymes continued to settle. The patient showed worsening of tachypnea. The ABG showed CO2 washout and hypoxia. He was started on oxygen with the NRBM. On day 5, CCT whole abdomen was done, which showed moderate acute pancreatitis, CT severity index of 7 with peripancreatic fluid collection, moderate ascites and necrosis more than 30%, less than 50%. His TLC increased to 27,000, 80% neutrophils. The pancreatic enzymes at this stage were below 100. CRP rose to 148. Albumin was low. He had developed bilateral pleural effusion and tachypnea was persisting. Albumin infusions were started. Low dose diuretics were given. BiPAP support was started intermittently. Antibiotics were upgraded to meropenem and teicoplanin. Metronidazole was continued. TPN was started. By this time, the patient was also having hyperglycemia, so we also started the patient on insulin. By the day 10, the TLC rose to 36,000. All cultures till now were sterile. The family was counseled about the poor prognosis and explained about the worsening condition. On day 12 onwards, there were signs of clinical improvement supplemented by improvement in laboratory markers, and the patient was put off BiPAP and he was allowed oral liquids. Thereafter, clinical as well as biochemical improvement was observed. He was accepting soft diet well on day 14, passing soft stools, and the abdomen was soft and he was on intermittent oxygen. Bilateral pleural effusion persisted, which was mild to moderate at this time. Pulmonology opinion was taken and we were advised to wait and watch. He was discharged on day 15 on symptomatic treatment and insulin. So this was the course of the patient during hospital stay. By this time, he was having mild tachypnea and dyspnea on walking, say about 100 feet or so. Apart from that, there was no symptom. His abdomen was soft. He was accepting a soft diet. He was accepting liquids. He was passing flatus. He was passing 2 to 3 episodes of soft formed stools per day. The distension had gradually reduced. The abdomen distension had reduced. He came to OPD for follow-up on day 5 post-discharge. He was asymptomatic with minimal left and mild right pleural effusion. So on day 12, we continued to observe the patient. On day 12 post-discharge, the left-sided effusion had resolved totally with minimal resolution in the right-sided effusion. And a diagnostic pleural tap was done at this stage after taking a pulmonology review. So this was the unique thing, the unique finding in the reports. The pleural fluid TLC was 1620 with, we can see there were 50% eosinophils. The sugar was 95, protein was 6.37, albumin was 2.8, ADA was 16.5. So our rare finding was eosinophilic pleural effusion in a patient suffering from acute pancreatitis. The patient is on symptomatic treatment and on follow-up for the assessment of pleural effusion. So this was in a nutshell our case. So I have presented CT severity index in brief. This is how, on the basis of CT findings, we are able to make a severity assessment of the pancreatitis. In this case, the patient was suffering from moderate acute pancreatitis, which has a moderately high mortality. And this is in brief. So talking about eosinophilic pleural effusions, they themselves are an uncommon entity. Out of all the pleural effusions, only about 13% are eosinophilic. The causes range from malignancy to idiopathic to parasitic, parapneumonic, tubercular, connective tissue diseases and cardiac. But our patient had none of that. The review of literature showed 5 cases of eosinic pleural effusion in association with acute pancreatitis and a few more, 2 or 3 more in association with chronic pancreatitis. So eosinophilic pleural effusion is a rare complication of pancreatitis which occurs due to leakage or rupture of a pancreatic pseudocyst or pancreatic duct disruption. CT scan or ERCP performed under pressure usually demonstrates the connection between the pleuropancreatic connection, and our diagnosis is clinched. Although in this case ERCP was not done, the diagnosis was clear. It was an acute alcoholic pancreatitis. Pancreatic pleural effusion is usually left-sided but can rarely be right-sided, as it was in our patient. The treatment is controversial because of the rare incidence and lack of data. Endoscopic transpapillary stenting or nasopancreatic drainage placement has shown results. Medical management with bowel rest and somatostatin has mixed outcomes. So as per our case, since it is gradually resolving and the patient as of now is very mildly symptomatic because of it, we are observing. If required, we may drain, and it is a learning curve for all of us. For me, the gastroenterologist involved, the pulmonologist involved, it is a learning case for all of us. So this was the case in brief which I wanted to present about a very rare finding which we came across. Thank you.